There you go. Um, okay, so the common wisdom is that in order to take or put a stretch and actually extend collagen, normal collagen, it takes at least 15 to 20 minutes to start getting any hysteresis in it at all. And it probably takes a lot longer than that in degenerative collagen, which is much thicker. So unless you're prepared to do mobilizations, grade 4++s, for at least 15, 20 minutes, you're not likely to get very far with it, which is why dynamic and serial sprints were invented. So it's a bitch when you find these things. And you can't really do them by stretching exercises if you're stretching positions and exercises if you're looking at a spinal joint, because if you think about it, the hypertrophic capsules and ligaments are much thicker than the normal ones. So the stretching you're going to do to a region is much more likely to destabilize a normal joint structure than it is to stretch a tight joint structure. Does that make sense? It gets really difficult when you deal with these. Fortunately, it doesn't happen very often at all. When it does happen, it's due to a disease process like rheumatoid or ankyspon, or it's due to a trauma where you've got adhesions and exudate thickening in there. So you don't come across it too often. Most of the stuff you're going to be treating will be subluxations and very amenable to manipulation. So this is probably what we're going to be looking at mostly today. So the onset, you need to destabilize the joint basically for this to sublux. A healthy joint will not produce subluxation. Now you can sublux a joint with trauma, but it's an awful lot of force, and these are surgical subluxations, really partial dislocations, and you end up with a real mess. You tear through ligaments, you tear through capsules, and you end up with a severe inflammatory reaction and weeks and months of pain. This is not our stuff. Our stuff is episodic, minimal trauma, if anything, mostly a triggering event rather than overt trauma. So you need to destabilize this, and there's a couple of ways you've got to do it. One is the Australians' favored method when they first came up with this stuff, and that was you suffered a trauma that produced pain inhibition. Now that's very significant trauma to do that, and the pain inhibition went on long enough that it then converts to reflex inhibition, which produces dynamic instability. So you have a neutral zone instability where the muscles are not doing their job because they've been inhibited by pain, and the neutral zone increases and increases and increases because there's a continuous negative feedback. As the neutral zone gets bigger, the feedback gets better, so the reflex inhibition increases and you get more neutral zone and it increases and so on. So you get this negative feedback all the time. You then hit the end zone structures, and the end zone structures basically break down. And that's your end zone instability. Or you can do this for mechanical stress. Obviously, trauma, you tear through the ligament and you've got an unstable joint. It's really not what we're talking about, though. Mostly what you're going to find is cumulative trauma, leg lengthening causing excess stresses, hypomobility causing stresses on proximate joints. And you see this all the time with post-surgical stuff. For disc, where they're doing fusions on the lumbar spine, they'll fuse L4-5 and then they fuse L3-4 or L5-S1, and eventually they can end up fusing the entire bloody spine. Some surgeons, in fact, say, if I'm going to fuse one level of muscle, fuse the whole spine and get it over and done with. So there's two ways of getting to the end zone instability. Now, the end zone instability is where you can get subluxations, but you don't have to. So you can have a continuous instability, and you've all got those, actually. You all have joints that click on a regular basis, and you can make them click as you want to. Now, that clicking, that predictable clicking, indicates either a tendon flipping over something or, more usually, a minor instability. And that can go on forever until the whole joint becomes degenerate and gets stiff. So if you're dealing with that, where this thing isn't subluxing, not subluxing, subluxing, relux subluxing, if you like, then your treatment for that is going to be relieve the stress on it. So if this is caused by a traumatic incident in the past, you can't relieve that stress. There's nothing you can do about it. But if this is now caused by a proximal hypomobility or long leg or whatever, you can deal with that. Find it and you deal with it. You then do stabilization and then you do movement rehab. So that's fairly normal. But the enzyme instability can become a biphasic instability subluxation. So the matrix of this is instability, and every now and then it will sublux. Now, why it does this is probably an accumulation of two different things. One is the appropriate or maybe inappropriate force that triggers the subluxation, and then the appropriate force that resubluxes. So it's really a matter of luck rather than predictability. Or you have a gradual worsening of muscle control, and then one day it just subluxes and it stays sublux for a while, and then something nudges it back in again, and then you have dynamic stability for a little while and off it goes again. So, but this is typically what you see with this type of subluxation, is that you'll have periods where there is no symptoms at all, and then bang, they're on there, and they come on pretty suddenly. They'll wake up with it, they'll twist to pick something up and that's got it, and so on. So that's fairly typical. So now your treatment for this is stress relief, get the hypomobility or whatever it is that's causing the problem done, manipulate it. You can do those, and you'll do them all together actually. And then stabilization, which you usually don't need to do with these because your manipulation will stabilize it, and then movement rehab. It's a movement rehab that's a problem because people won't do it. They need to do this for a long time and they simply won't do it. One way around this is use a muscle stim on them, and that usually keeps things good for quite some time. And get them to buy one and put it on 2 or 3 times a week, although the lazy bastards won't even do that often. So that's the etiology of basically the subluxation. Do you have any questions there? Is there anything on there that sort of goes against anything you might have learned previously? No? Now, remember what we're talking about is models. None of this has been proven, and the chances are none of this ever will be proven, because I don't know how amenable this will be to research. And certainly most of the researchers are not capable of looking at something like this and dealing with it. Most of the researchers are fairly mediocre, but even the good ones are going to have trouble trying to work out how to work the theory behind this, if you like. Is that okay? So think of it this way. I've got a joint, flexes and extends. Yeah, the spinal joint anyway, goes up and down, up and down. In fact, they all do this. Whether if you're side bending to the right and left, it still goes up and down. If I side bend to the right, it'll extend. If I side bend to the left, the right one will flex. If I rotate, it's side flexion, so one will go up and one will go down. So this is all these facets can really do, apart from a couple of specialized levels that are designed to rotate, but these are nearly all flexion and extension. And if they do it asymmetrically, one going up and one going down, you'll get side flexion, rotation. Does that make sense? So if you think about this, if this joint is stable and it's moving properly, you'll get this happening. Nice, no problem at all. If it's not, though, this is a way to envisage it. If this is unstable into flexion, it can do that and get caught. All right, now what's actually catching it, I have no idea. But again, we're using a model, but the model fits the facts. And what we find is, if I try and move this into the range it's stuck in, and we know it's flexion because I've just told you, but even if you didn't know that, when I tested flexion, I would get a normal end feel from it, possibly a bit softer because it's been stretched out there. But qualitatively, it's normal, it's capsular. If I try and take it out the subluxation, it won't come out. That's why it's jammed. And what you'll get there is a completely different end feel. It is now jammed up. And it feels jammed. That's it. It's not bony. There's some life to it. It's not dead. There's some life to it, but it won't move. So you get this jammed feeling. Now, if you think about it, if I'm going to manipulate that, I would never manipulate it into a normal end feel. So I would never manipulate this into flexion. I wouldn't manipulate it against the abnormal end feel that way. Is that okay? So that's the model we're using. This subluxation is jammed at one end of the range and it has no movement into the other end of the range. Now, this works fine in the spine. In the periphery, the model doesn't work quite as well, providing you think of it literally. If I sublux the elbow into flexion, I would have absolutely no extension whatsoever. You never see that. But if I was to sublux the elbow into medial rotation of the ulnar-humeral joint, I would have no lateral rotation, which means that I couldn't get flexion, because you need flexion as a conjunct movement for, you need lateral rotation as a movement to gain flexion, and medial rotation of the ulnar-humeral joint to gain movement into extension. So if the subluxation is into a conjunct rotation, you'll lose some, but not all of the primary movement. The sum you'll lose is the amount that joint needs to get full range of motion, and that's going to vary from joint to joint. So the ankle, for example, in order to dorsiflex the ankle, you have to laterally rotate the talus. The talus in the mortise, yeah? If this is subluxed into medial rotation, then you can't get full dorsiflexion. You'll never lose all of it. This thing won't be stuck in plantar flexion, but you can't get the end range of dorsiflexion because it's missing that lateral rotation. Is that okay? Now, they'll get names like this. So this is typically called an anterior talus, which is a complete misnomer, because if it was anterior, it means it couldn't slide posteriorly, in which case I would have no dorsiflexion at all. It's a misnaming. All right, it really should be labeled as a medial rotation subluxation. You good? Okay, so this is sort of a diagram looking at that. So the top part is normal range of motion. And you have two barriers at each end of the movement. One is the physiological barrier and one is the anatomical barrier. Now, the physiological barrier is pretty much always muscle tone. And mostly you work in that mid-range. You never work at the extremes of range. Almost all of the function you do everywhere is in the mid-range. Now, if you take it through full range of motion, what you'll do is you'll come up against a physiological barrier. And now it needs passive forces to take it through that physiological barrier to come against the anatomical barrier. So I can do it as a therapist. I can test passive range of motion, and I've got to really push on this, and I'll get a composite end field when I do that. I'll get the end field, which is either capsular or whatever it is, but I'll get the normal end field, but that's overlaid by the feeling of the muscle. So you never feel capsule, you'll feel capsule plus muscle. You good with that? So this is where your ranges move, is between the two physiological barriers, and usually not the full range anyway. When you do end up hitting that anatomical barrier on a regular basis, you end up with Charcot joints, and that's exactly what happens, because neurological diseases end up weakening the muscle, reducing muscle tone, and so that anatomical barrier gets hit over and over and over again, and then it breaks down. You get degeneration, Charcot joints. The big example of that is neurosyphilis. It's certainly not the only one, but it's a massive cause of this, and they end up with really severely degenerative joints. So that's how your joints normally move. Now, the model is we get stuck at the end of the range between the two barriers. Now, I have no idea if this is true or not, all right? But the model works. So it gets stuck between the two ranges, and this is where it functions. It's got no mobility. So the only way it can really move is against that normal barrier. So what it's going to do, if you leave it where it is, it's going to stretch out that barrier and possibly destabilize that range even further. And what it may be now is maybe popping back in and out. So the more unstable this gets, the more easy it is to sublux. Now, if I want to manipulate that, I will thrust it in this direction, the green arrow. But I would never thrust it in the red arrow's direction there. all right, up against that normal end fill. Now, the thrust has got to be controlled. You need high speed, otherwise they'll guard against it, but you need high speed, but you have low amplitude. And as soon as you start getting this range of motion, then you're in trouble because you've gone through the physiological barrier and now you're hitting the anatomical barrier. And if you're a real cowboy, you can actually start tearing stuff at the end of range. And there's two things you're doing wrong. One is not controlling the range of motion of the thrust, and the other one is you're thrusting in the wrong bloody direction. So this isn't difficult. You only ever thrust against abnormal end fills. And so the abnormal end fill is whatever is stopping this from moving back into that normal range. And you tell that by this jammed end fill. Does that work for you? So again, we come back to this. So there it is stuck in flexion, if you like. What I'm going to do is I'm going to nut it and bring it back into that range, but not so hard that it's going to do that with it. That's essentially it. You can manipulate, basically, if you just want an effect, you can manipulate this joint any way you want to, and you'll get a neurophysiological effect. But I've done both. I've done Syriacs, where you manipulate away from the pain. If that doesn't work, you manipulate towards the pain. I've done other techniques where it doesn't really matter, you just go for it. And what you get is a much shorter duration of relief with this. With one manipulation, you should be able to get, easily 3 months is certainly not unusual before the patient goes. Even if you don't do anything else to them, 3 months is easily achieved with a single manipulation. Okay, sometimes they won't come back forever. Now, it's not because you haven't done them any good. It's maybe, but you've set them off. They've come, they've phoned in. You've seen them, and they're fine a week later, 2 weeks later. And if that was the case, they'd come back and see you again. But you don't see them again. Presumably, they haven't done anything to jam this thing up again, or they're dead. But 3 months is not unheard of, and certainly it's actually common, and certainly 6 months is very reasonable. The manipulation has an added effect. When I manipulate this joint, it immediately stabilizes the segment as much as it can. So these hypotonic weak muscles are having massive input put into them by the manipulation, and they come alive. Now, if they're seriously atrophied, you can't do that. There's nothing you can do about that when they're seriously atrophied. But if they're not seriously atrophied, that manipulation will activate them. And now it's stable. That's stable. And what you want to do now is take advantage of this to do movement re-education. So you can, because you can't do movement re-education if those muscles are not working. I think the idea of keep pushing your fingers into a muscle saying, come on, tighten up, make it contract, is silly. You actually don't need to do that. If you want to get that muscle to contract, just do 5 or 6 seconds of PAs over that segment and watch it come alive. You don't need to have this voluntary thing, because this isn't a volitional function anyway. This is automatic. But having got that, then you can either keep it alive by using muscle stim on them, or you can re-educate the movement. As I say, I think re-educate is mostly futile because they won't do it. Now, if your manipulation only lasts a week, then do it again by all means and see what's happening. But if this is continue happening, they're having episodes every week, this is very unstable, and you've got a job on your hands. I'm not sure what to tell you about that. You're going to have to look at what they're doing, change what they're doing, and they're in trouble. And sometimes stim works, sometimes it doesn't. The other issue is, because this has such a massive neurophysiological effect, not just on muscle tone and muscle activation, but also on pain. Remember, this is exactly what you've done. Even if you don't manipulate, you just do wobbles, PAs, you will activate the muscles, and you will decrease the pain to some extent. So the patient feels much better after you've done it, after you've done the manipulation. They stand up and go, yeah, that's pretty damn good. Almost no pain on movement. And then they come in next day or the day after that, and they'll say, you know, this was good for a few hours, but gradually it got worse. Now, that means the manipulation did not have a mechanical effect. If it has a mechanical effect, it will recur suddenly. They'll wake up with it, or they'll twist and do something. It won't be this gradual worsening over hours. Similarly, if you manipulate it and you hear a click in setup, not just in the thrust, but in setup, don't manipulate again. Get them up, look at them, stand them up, move them. If they're much better, that's it. Then the next time they come in is, how have you been? Basically, well, it was good for a couple of hours, then it gradually got worse. That's exactly what's happened. You've had a neurophysiological effect. It was great. It's much better now than it was. It's probably 80% better than it was. Then manipulate it again. If they come in and say, you know, it's good for a couple of hours, you just got to click out of this thing. Set them up again. If it clicks again this time, ignore the click. If it's the same click, ignore the click, manipulate it, and it still happens. Is that okay? All right, do you have any questions on that? No? Now, there is, I think this is, I'm hoping I've still got this up here. No. Just give me a minute, I'll see if I can find what I was doing here. Oh, hang on, I know where it might be. Yeah. Oh, bloody internet in this country. Because I want to talk to you about treatment planning a little bit more. Try and get this thing happen. Okay. Be right with you. I think this is my computer, not the internet. Talk amongst yourselves. Okay. All right, can you see that okay? So looking at treatment planning, now your treatment planning is done from your diagnosis, all right? Whatever it is, whether it's biomechanical dysfunction, disc hernia, doesn't really matter, but it's based on your diagnosis. So this is general now. So you will have an ideal treatment from that diagnosis. This is a treatment that you would really like to apply because it fulfills all of the criteria that that diagnosis needs. Let's talk about biomechanics because it's a little bit easier. So I've made a diagnosis. This is a subluxation. I want to manipulate it. That's the ideal treatment. I want to do movement rehab, stabilization, all the other stuff. All right. Now, there are things that are going to frustrate that. And one of them is what the patient wants. Now, it may be this patient has had bad experiences in the past with other practitioners, chiropractors, other PTs, and they really don't want it. Now, if you insist on doing it, that becomes criminal assault, actually. You can go to prison for it. So it's best not to. You can try and convince them and all the other stuff, but don't do it if they don't want it. So that's your number one concern. Is the patient okay with it? The next one is what the physician wants. And this one you can ignore. You've got full ability to pick your own treatments, as far as I understand it. On the other hand, there are consequences to what you do. It may be that physician won't refer to you again. So you've got business things to think of there. You also have to wonder about your competence or competence, if you prefer. Are you good enough to do the technique that needs to be done? And the only way you get good at new things is to try doing them. So you are going to work right on the edge of your level of comfort at time. But if you don't do that, you won't get better at what you're doing. You'll get better at what you're doing because you're doing it, but you won't get better at new things. So sometimes you have to say, well, yeah, I'm not going to kill him if I try and don't work, basically. On the other hand, if you truly have no confidence in your ability to do this, then you're better off asking somebody else to do it. And finally, there are contraindications. All of this will impact on your ideal treatment. So is there any reason why I can't manipulate this? Now, there's only one contraindication, one, to assessment techniques and treatment techniques. Assessment techniques have contraindications as well. For example, if you believe they've got a high cervical fracture, do not do range of motion testing. Do not do fracture stress testing. All right. So, but treatments, absolutely wrong. So the only contraindication is the patient will not tolerate what you want to do to them. Now, underneath that comes all of the reasons why they may not tolerate it. There may be bone or vascular fragility. There may be collagen fragility from disease processes. There may be psychological fragility. I remember watching, I was in a clinic in Edmonton years ago, and there was another therapist working with me, and we both had downtime. So we're standing behind the reception desk, just in the door of the office and reception area, and a woman walks in, and I said to the therapist, I said, you take her. He went, no, you have her. I went, no, you have her. Neither of us wanted, she hadn't said a word, not said a single word as she came into the clinic, and neither of us wanted to treat her. I ended up getting her, and it's a real bloody pain in the ass. So you want pattern recognition, that was pattern recognition. But the only way you can tell, you haven't got a degree in psychology, the only way you can tell whether or not you're comfortable is almost always when you're talking to them. And this is another reason to really ask them about their pain rather than numbers. You say to somebody, what's your pain, 0 to 10, they go 7, you've got no information there at all. Actually, you've got no information at all. Is 7 a severe pain? What do you think? Is that? Actually, I'm getting off another topic. We'll come back to it. But you need to explore their responses to their pain, their responses to any disabilities they've got, their psychology. You need to find out what sort of personality they've got. If you figure that they're going to be a problem, do not manipulate them. Okay, if you believe that's going to be an issue. If you think everything you do is going to be an issue, don't treat them. You know, it's different from being a pain in the ass to actually making this person into a dithering idiot who's going to sue everybody if they can get away with it. For this course, dizziness will be a contraindication. All right, it won't always be. Once, and I'll give you a good grounding on this on the course, but once you determine that the dizziness is not VBI and it's not from anything else you can seriously adversely affect, then you can manipulate it. I manipulate next to get rid of dizziness. But until you've got that degree of confidence in your ability to diagnose dizziness and headache, come to that, then it should be a contraindication to you. Okay, and then the last one, well, it's not the last one, there's other minor stuff, but obvious congenital anomalies. And there's really a good reason for this. And that is anomalies don't occur in isolation. So let's say somebody who's got syndactyly, so they got fingers fused or too many fingers or webbing in there. This is not a problem with the hand. This is a problem from the embryological block where that congenital deformity lies. So everything in that block is affected, and that may well include the vertebral-basilar system. So if you're seeing these, and it's birthmarks, port wine stains, all of this stuff, if you're seeing this stuff, be extremely cautious about what you're going to do with this patient when it comes to mechanical treatments. Is that okay? All right, so I'm going to get back on one of my horses here, pet peeve, and that is pain. Are you using pain scales? I don't mean for insurance purposes. I mean, are you using them clinically?
I will use them definitely for WCB patients, just for the reporting.
Different animal. Clinically, though.
Every so often, when I have a really hard time gauging with, like some people are giving me hard descriptors for their pain, I can't gauge how much their pain is, because it's essentially so severe that I ask them at the beginning, and then I won't ask them every session. But as we look like we're improving, I use it sometimes to gauge their level of how much they feel they've improved, but not a lot.
Okay, so if they say, actually, there's a better way of doing this. If you say to them, like, if you think about it, your language scale for pain is no pain, mild pain, moderate, severe, exquisite. Yeah. Now, you're putting numbers on these, and you're cutting those numbers up even finer. We got 5 of these, you've got 10 units in your pain scale. All right. Now, the more units you have, the less reliable a scale is. So if you divided that up into 100 instead of 10, yeah. So you've got really 0 to 5 would be better for you. Now, if I say to somebody, this is your choices for pain, it's you've got none, you've got mild pain, you've got moderate pain, you've got severe pain, you've got exquisite pain. Could they answer me?
Yes.
Yeah. Yeah. Okay, so let's say they say it's severe. All right. Now, if I want to put a number on that, what would that number be?
Like a 9.
8 or 9, yeah? Now, remember, what you haven't done here is you haven't had to talk about what a 10 is. Because what is a 10? Everybody uses something different. What are you using?
Yeah, most times I say that 10 is you being in the emergency and you're having morphine.
Okay, how many people have you had in your clinic who said it's a 10 and they're in your clinic? So it doesn't work. I did use this at one point. I think I've only used it on a couple of patients, but I used it on a woman I was in Yukon teaching a course. And I said, okay, this is your scale, 0 to 10. 10 is where you're going to commit suicide unless it goes away. She said, it was a 10. So I said, really? She said, yeah. She said, they stopped me. I was on my way to the Yukon River. I was going to throw myself in and they stopped me from doing it. Okay, fine. But right now, with those 5 things, you put a number on these, you don't have to worry about what a 10 is. You don't have to explain it. You also, is the scale you're using the same scale as the patient's using? That is your scale linear? That is, the difference between a 2 and a 3 is as different, same as the difference between an 8 and a 9? Or is this logarithmic? What is this? Non-linear. So you don't even know if you're using the same scale. And what matters is not what the number is, it's what the patient perceives it as. Now, if I have a patient come in and say, okay, I got really severe pain, and I say, well, what do you do? Well, I do everything. But all of it gives me really severe pain. As far as that patient's concerned, that's severe pain. It's not my opinion on what severity is, it's theirs. I can't objectify this. Can I? Giving it a number doesn't make it more objective. Now, the other thing with this is, give me a number, 7. Okay, fine, move on. And that's not the way pain works neither. It's certainly not what the patient wants. So if somebody comes and says it's a 7, what's your follow-up question to that? Or do you have one? And it's the trouble with insurance forms and WCB forms. They do exactly this. What's your follow-up to that question?
You could be asking them like, what makes it a 7 and not like a 5?
No, not yet.
No, okay.
Is it always a 7?
7, yeah. I say constant 7. Okay.
Yeah. If not, where are we? Is 7 average? Is 7 max? Yeah. What's your minimum? What do you average during the day? Okay, now we got that. Now, what do you do to make it a 7? So these numbers actually start to be a little bit better. Yeah, they're more usable. The worst pain you can imagine is the other one, isn't it? Well, I'm not sure what my worst pain is, but I imagine a rusty, red-hot knife doing something to me. Yeah, probably disemboweling me slowly. Now, under that circumstance, every other pain is a 3. I've got a pretty good imagination. So the patient wants to talk about their pain. It's one of the major reasons they're in senior. Their doctors fob them off. Oh, yeah, tell me, give me a number. Yeah, I was right. And this is why they get sued and you don't. It's because they like you because you're interested. As soon as you start talking about numbers to them, then they're not interested. You want to get a number for your insurance company or WCB, you talk to them about it and you come to an agreed upon number. What number do you think this should be? Why? And if you want to find out if they're improving, and they can, well, it's still severe. Can you do more than you could do? Because if they could, that pain's improved. If they've got less function than they had before, you just made them worse, basically. Yeah. So you can now link that pain level they've got with their activity level and improving on that. But these numbers were actually designed by researchers so that they could quantitatively mark improvements with interventions or worsenings with interventions. And that was all it was, which is fine, but they were never meant for clinical practice and it's become a lazy crutch. Talk to the patient, find out what they want and what they think's happening. Okay. Manipulation should have an immediate improvement. If this thing isn't getting better in 2 or 3 sessions, then something's wrong. Your diagnoses are wrong, the treatment technique's wrong, there's something wrong. Okay. Personally, if I'm still seeing the patient after 4 treatments, I'm bored, I'm ready to move them on somewhere else. I find it extremely boring seeing somebody for more than 4 treatments. But you do expect to see immediate improvement. Now, what can happen, and this does happen, is you'll manipulate them, they'll feel immediately better, much, much better. And they'll say, this is good. And it was good for probably the rest of the day, and then woke up and it was worse. And it's been worse since I woke up yesterday. Now, you haven't done any damage. If you'd done damage, they would have felt that pain immediately when you did the damage. So you haven't done any damage here, not as far as pain's concerned. And probably what's happened is you've shifted things around, the joints got inflamed, and now what you have to do is let it settle down. Okay, that's generally due to bad technique. But not always, sometimes it isn't, usually it is. So just let it settle. And at the end of that settling period, they should be feeling a lot better and treat it as an inflammatory condition from that point on. If they are a lot worse after you've done it, then manipulation is either gone the wrong way or you actually have done some damage. Try not to do that, it's not good. Okay. All right. This is going to be a short session unless you've got something to ask me. This is going to be the last one on Sunday, I think, for a while. I've got to figure out how to do this. The Calgary group will be finished long before the Edmonton group does. So what I need to do is pick up, but I'm working weekends now. I've got 8 weekends between now and end of November. And I wouldn't mind being able to go away for a weekend at some point or another. But it's going to be difficult to get this in. But the Calgary group, I'm basically going to stop the Sunday sessions. But what I want to do with the Calgary group, and I want to, is after the 4th session, we're going to give it about a month, and then we'll come up to the written exams. All right. I want to do some sessions between the end of the classroom stuff and the beginning of the exams to prep you for the exams. Now, I can also do this in the evenings, and I've got no problem. And what I'll do in the evenings, I think, is I'll cover any questions you've got for about the content, but I think on the evenings as well, we can start looking at some of the questions on the written exam. All right, but I need to come up with a time. Now, I don't mind, I'm not going to do this on my own. All right, what I'm not going to do is sit here with an exam paper and go through it on my own. So as long as somebody's there, I'll record it and everybody can have it, but I just need somebody to be there. So it'll be in a weekday and it'll be in the evening, I think, which I can't see it working during the weekday. It has to be for you. I would guess it's going to have to be the evening. Right.
If it's like Wednesday, Thursday evening, I can attend.
Sorry?
I'm in Calgary group. So
Yeah.
if it's like Wednesday or Thursday evening, I can attend.
Okay, I think you're the...
Yeah, in between the course and the exam. Yeah.
Does anybody have a problem with that?
Evenings are good.
Any evening for you?
Yes.
I probably could make Thursday evenings, but Wednesday evenings would work, but we'll see what works best for you and for everyone and go from there.
Thursdays are okay for me.
Thursday works better for me as well.
Thursday's good.
Thursday?
Thursday works better for me.
Me too.
Okay. What time?
Like late, 8?
Yeah, around
You're
7
going to
or
get
8.
right in the middle of my bloody evening, are you?
I guess the later the better. I don't know. For me, I'm okay. Evenings are great.
All right. Thursday at 8 then. All right.
And
Yeah.
Jim, so Friday is it 3 o'clock starts, right?
Yeah.
3.
Yeah.
Okay.
Yeah.
And I'm driving from Grand Prairie. It's like 8 hours. So on Sundays, what time we are approximately done?
My guess will be around about 3:30, somewhere in there.
Okay.
Maybe 4. What I do is I look at your eyeballs and seriously take note of how much they're spinning and base my timing on that. It's when I bore me, really. But it'll be between 3 and 4, I would think, on Sunday.
Okay. Yeah. It's just as we are 2 people, me and Sharath, both are coming from Grand Prairie. So we both have to drive back because both have shifts on Monday, 8 o'clock. So
yeah. Well, good luck with that.
thanks.
I appreciate your commitment.
No problem.
Okay. All right. I think that's the only housekeeping thing I've got. Yeah, we'll start that from next Thursday, so we can keep this going. All right. We don't have to have a break. We'll just keep that going. And I'll send out a notice to everybody with this thing. All right. Anything else for me? Okay, we'll get back to you Sundays. I've got a football game to watch. Like real football, not the...
Okay, so are we having any session next Sunday? Probably not.
No, not next Sunday. So we'll start next Thursday.
Okay.
Oh, actually, I couldn't. No, hang on. Where are we? Yeah, I'm still stuck in here. I can do next Sunday, actually. Yeah, next Sunday.
That's a long weekend, so just in case people don't show up. It's a long weekend next Sunday.
Oh, okay. I knew there was that's
coming.
Labor Day, isn't it? Let's not do that because last time I did that, I was sitting on my own. So let's start this coming Thursday.
Perfect.
Yeah, that's fine.
Okay. All right. I'll move all the dates over and we'll start Thursday evening.
All right. Thank you very much.
Sounds
Okay,
good.
guys. Well, have a good weekend. What's left of it?
Thank
Yeah.
you.
Thank you.
I want to see how my team's doing. Not great, I wouldn't think. But there you go. All right, guys. Have a good day.
You as well. Thanks.
Bye.
Bye.
Bye.